Thank you very much.
Thank you. So I'm sure all of you would have come across an acute neurological deficit whilst doing their own calls. Bearing in mind that not all focal neurological deficits are stroke. There are lots of other coexisting neurological events which can contribute to a focal unilateral pathology. So today's talk, I will start with giving you 3 cases with similar presentations, but different etiologies behind their presentations, and see what you make of it. And then I will summarize what is the current consensus on acute stroke treatments. So hope you will enjoy. So the first patient, he is a 64-year-old man who was brought in by the ambulance after being found confused in the town center at around 4 o'clock in the afternoon. And you are doing your medical on call. You see him in the ED at around 5 o'clock, which is an hour after he's been found by the ambulance. He's lying in the couch. He's drowsy, but opens his eyes on your verbal commands. He's not verbalizing coherently. His GCS is E3, V2, and M5, which makes it 10 out of 15. And you notice a right facial droop. You score his NIHSS score, which is the scoring system for the stroke, as 9. Tell me what you think, what you will do. Any thoughts from the audience? Okay, and anything else you want to know before you go for a CT head? Excellent. Glucose, VBG, and the blood pressure. So his glucose is 18.5. His blood pressure is 180 by 96. And blood gases show a lactate of 0.7. The rest, everything is okay. So yes, blood sugar is high, blood pressure is high, but neither of them demands an immediate treatment. So you want to know what his CT scan is showing. That's the slice of his CT scan, essentially a normal study. What next? Absolutely. So you call the stroke team, and stroke team, you're lucky you're in a hospital where stroke team is at hand. They come along and they confirm that patient has a acute left MCA territory infarct, which is rendering him to be dysphasic, and dysphasia is being perceived by other team members as being confused, but he's essentially having a global dysphasia along with mild right-sided weakness. So he gets thrombolized, and next day his NIHSS score is 1. So case 2. This one is a 46-year-old man who has been brought in by ambulance after being confused in the town center at around 4 o'clock. You're seeing him in the ED at around 5 p.m. in the evening, an hour after he's been found. Again, he's lying in the couch. He's drowsy but arousable, not verbalizing coherently, and his GCS is 10 by 15. He's got a right facial droop. His NIHSS score is 9. What would you do? The same, you will ask for a blood pressure, glucose. His blood pressure is fine, 140 by 80. His blood sugar is 6.5. And his lactate is 1.4. So no immediate action although there is slight derangement, but none of them need immediate attention. So he should go ahead with an urgent CT head. So that was his plain CT head, which shows a dense left MCA. As you can see into the left hemisphere. And that's a marker that he's got an acute proximal left M1 occlusion. And that in a 46-year-old man is a marker of a severe stroke. He's going to get worse if he's untreated. And current evidence is that if the clot is more than 1 centimeter long, then they generally don't respond to intravenous thrombolysis. So this patient is taken in a blue light ambulance to an urgent hyperacute stroke center where they have neurosurgical facility available. So he gets thrombolized on his way. On reaching the thrombectomy center, he underwent an urgent mechanical thrombectomy, and next day he recovers fully and goes home in another 3 days' time. So then this gentleman, who is 54-year-old, and he is found collapsed in the toilet around 4 o'clock. You're again seeing him in the ED at around 5 o'clock. Again, he's lying in the couch. He's drowsy but arousable. He's not verbalizing coherently, and he intermittently wants to snore as if he goes in the deep sedative state. His GCS is 6/15. He's got a right facial droop. He is anarthric, which essentially means that he can't phonate. So anarthria is a step further to dysarthria, where you lose your phonating abilities. His NHS is 20. He's clearly acutely unwell. What are you going to do about it? Well, yes, absolutely. So glucose is fine. Whilst he's snoring, airway is at risk. So we'll ask the critical outreach or on-call ITU registrar to come and support you. So initially, we will try to secure his airway through an NP airway, which will help in maintaining the upper airway patency. But if he deteriorates further with reduced respiratory movements, then he will need an intubation. So what do you suspect in him? Yep, so but he hasn't complained severe headache, but his GCS is low and his NHS score is high. He's drowsy. Yes, but he's presented within an hour of his onset. So yes, I agree with the brainstem. Had it been an MCA event, he won't lose his GCS that quickly, because for his malignant MCA edema to build up, it will need at least 6 to 8 hours. So initially he will be alert, but he won't be able to communicate. He might become agitated, but getting drowsy, losing their ability to speak, and being snoring is a marker of a brainstem or posterior circulation stroke. And at this point, it can be a posterior fossa bleed, or it can be a ischemic stroke. So he gets an urgent CT head, and what you can see in the scan, can anybody pick it up? Yeah, but it's often difficult to pick up early changes. But in the brainstem area, there is a gray-white differentiation loss. And you can see a hyperdense basilar artery. You can see the white dot in the center. That's a hyperdense basilar artery. When we did the angiogram, that's the basilar artery, and you can see a flow void in the distal basilar artery. So he's got tip of basilar artery occlusive clot, and that's preventing a contrast to flow through it. It is a large clot, and he's got a significant neurology. So again, this patient has come within the thrombolysis window, but thrombolysis alone won't cut it. He will need an urgent mechanical thrombectomy. So although you can start him on intravenous alteplase, but he will need to be transported to a mechanical thrombectomy center to undergo an urgent mechanical thrombectomy. And if done within the correct time frame, chances of them making complete recovery are high, purely because they have presented to A&E so quickly. And if rest of the treatment, i.e. the systemic thrombolysis and mechanical thrombectomy gets in time, then you will see a better outcome. So when you are a resident and you are having to receive the patients at the front door, there are certain stroke essentials you've got to be familiar with. And these are the few bullet points I tell my juniors. It seems most of you are on board with it. So remember, the stroke thrombolysis is very time regulated. There's a narrow time window where you can thrombolize safely the patients, which is up till 4.5 hours from the onset. And you can do a mechanical thrombectomy for anti-circulation strokes up till 6 hours from the onset. For posterior circulation stroke, the thrombectomy window is longer, which is up till 12 hours. In some patients, you can do up till 24 hours. But whenever we extend the time window for mechanical thrombectomy, we need a bit more imaging support, i.e. either you need a CT perfusion study for anterior circulation stroke or an acute MR study for the posterior circulation stroke. The stroke care is driven through the NIHSS scoring system, which is 0 to 41 point scale. Higher the score, more severe is the stroke. You can go to the nhsstrokescale.org website, which takes you through a training module where once you finish the module, you get a certificate for being NIHSS trained. It's a very useful scale. This is the scale we use to mark the severity of the stroke, and its scores are used uniformly across the world for using thrombolysis and thrombectomy. For example, to meet the thrombectomy criteria, the NIHSS score needs to be 5 or more. If it is less than 5, then it gets classed as a mild stroke, and you will have to deep dive more to do any aggressive invasive interventions like mechanical thrombectomy. Not that you can't do it, but you just need more imaging support to do that. So always check their blood pressure, sugar, and temperature, because very high blood pressure or low blood pressure, or a very high sugar or a low blood sugar, or very low temperatures can give you a focal neurological deficit, which then will come to you as a stroke mimic. And so unless you correct them, it will not be appropriate to thrombolize the patient. So somebody who is in hypotensive shock, their blood pressure needs to be corrected before you use the thrombolysis. And if somebody's blood pressure is more than 185 by 110, then you need to bring that blood pressure lower before you use the thrombolysis to treat the acute ischemic stroke. And the most common antihypertensive medications which we use are IV levodopa or IV GTN infusions. Levodopa generally favored, but yes, people who have bronchospasm or very bradycardic in them, we tend to use GTN infusion. So this is the 41-point scoring system. There are 11 domains to score in the NIHSS score. Hope it is visible to all of you. Can you see it? Is that any better? Fine. So it is quite self-explanatory. I won't spend a lot of time in that. But if you go through that web link, which I flashed on the screen earlier, nhsstrokescale.org, you will see the modules to practice on, and it's useful to practice. So this is the essential of stroke. This is the essential arterial anatomy we work on. So as you know, that the brain is supplied by two arteries anteriorly, the internal carotid right and left, and two vertebral arteries behind the right and left who join to form the basilar artery. The initial branch of the vertebral artery, posterior inferior cerebellar artery, supplies most of the inframedial part of the cerebellum. And then as the two vertebral arteries join from each side, the first branch of basilar artery is anterior inferior cerebellar artery. And then you've got lenticular branches of the basilar artery, which supply most of the pons and the midbrain. And then you get superior cerebellar artery, which is the pre-terminal branch of the basilar artery. And then the basilar artery terminates into the two posterior cerebral artery. Posterior cerebral arteries communicate themselves, not in all patients, but in vast majority of patients through the posterior communicating artery to the internal carotid artery. So 75% of the time, the posterior cerebral artery is a branch of basilar artery, but in 25% of the patients, posterior cerebral artery comes through the posterior communicating artery. So it's a caveat in the neurovascular anatomy, which we need to be mindful, because then it allows us to think about doing carotid Doppler artery, even if it comes out as a posterior circulation event, i.e. if you see a patient who has got a medial occipital lobe infarct or a thalamic infarct, we need to have a bit more understanding of their arterial anatomy before making more plans for preventative treatment. So that's the vascular anatomy of the blood supply of the brain. So as you know, the medial frontal lobe is supplied by the anterior cerebral artery, while the vast majority of the anterior lobe, including frontal, parietal, and occipital, is supplied by the middle cerebral artery. And then the medial occipital lobe is supplied by posterior cerebral artery. So the border zones between the anterior cerebral and the medial cerebral artery are these. So in the frontal lobe and in the posterior, in the occipital lobe, the border between the medial occipital lobe and the lateral occipital lobe is called as a watershed zone. So these are the two areas which take most hit if somebody comes through a hypotensive shock and they didn't have their hypertension corrected in a quick time frame. That includes people who lose their cardiac output and who do a CPR, or patients who remain in septic shock for a prolonged period of time. They develop hypoxic brain injury, and it comes out as watershed infarct. If you do the MRI scans, usually they will have symmetrical watershed territory infarct in both hemispheres in these zones. Your basal ganglia, which are primarily supplied by the lenticular artery branches of the middle cerebral artery, especially the proximal middle cerebral artery. So they are very sensitive to hypoxia and hypoperfusion because they are end-on arteries and they don't have a good collateral circulation. So when you get a hypoxic brain injury, and if you do an MRI scan, you will see the basal ganglia being hyperintense in the T2 and flare sequences of the MRI brain scan. So something to keep in mind. So as I was mentioning to you, stroke thrombolysis is licensed to be given up till 4.5 hours. By and large, first 3 hours, everybody is eligible But between 3 to 4.5 hours, evidence has emerged that people who have uncontrolled diabetes mellitus, who are on oral anticoagulant, or who have had previous strokes, they don't do very well with the stroke thrombolysis. It's just something to remember. If we were to do the thrombolysis for this group of patients, you'll have to take a high-risk consent because hemorrhagic transformation risk after post-lysis is higher in this age group, in this group of patients. In a typical large vessel intracranial occlusion, bear in mind that every passing minute, the person is losing 1.9 million neurons and 14 billion synapses. So it's not that you've got 4.5 hours to work for. You have to emphasize to the wider team, including the radiology team, that every passing minute is a 1.9 billion neurons lost. So in which group of patients you will do stroke thrombectomy? As I was mentioning, that if the onset of symptom is less than 6 hours, NIH score is more than 5, and you can identify a target where you can put a guide wire in and do thromboaspiration and clot retrieval, then you will consider them for urgent mechanical thrombectomy. So the important bit to remember in mind that you do need a CT angiogram, you do need a target where you can ask the interventionist to go in and take the clot out. Often you will come across the patients who have had stroke whose NIH score is more than 5, but there is no obvious large vessel occlusion to see. So that group of patients can have systemic thrombolysis, but since they don't have a target to work on, they won't be entitled for a mechanical thrombectomy. Sorry, can you hear me? Okay. So if time of onset is unknown, for example, you have wake-up stroke, then you can still do the thrombectomy, but you need more imaging support. So in addition to being able to see a large vessel occlusion in the CT angiogram and normalish looking CT brain scan, you will need a CT perfusion scan for anterior circulation strokes, and preferably an MRI brain scan for posterior circulation stroke to identify an ischemic penumbra. And if there is ischemic penumbra to save, then they will be benefited by getting an urgent mechanical thrombectomy. I hope that makes sense. So what if patient has come in a window where you can't do a thrombolysis and you can't do a thrombectomy? So they still need standard stroke care, which includes, as a starting point, do a direct swallow assessment. And not everybody is allowed to do a direct swallow assessment. Only the clinicians and the nurses who are trained to do a direct swallow assessment are meant to do that for stroke patients, primarily because of the evidence in the past that there is significant risk of aspiration and death from aspiration pneumonia if we try to feed somebody who is at risk of aspiration following the stroke. Current standard treatment for ischemic stroke is to give aspirin 300 milligrams stat and once a day for 2 weeks, and then change it to clopidogrel 75 milligram OD. There's a growing consensus on giving dual antiplatelet therapy to patients who had had a TIA or milder strokes for first 3 weeks, and then step down to single antiplatelet therapy, which is clopidogrel 75 milligram OD. And thus, dual antiplatelet treatment is more beneficial to that group of patients who have significant atherosclerotic disease burden. For example, you have a carotid stenosis, which is 70% stenosed from atherosclerotic disease burden, and they are deemed not suitable for carotid endarterectomy. So that patient will get the benefit of being on dual antiplatelet therapy. Statins are uniformly used for atherosclerotic ischemic strokes, standard dose is 40 to 80 milligram based on the patient's renal and BMI profile. If patient didn't have a CT angiogram, then we should do an urgent carotid Doppler. So I got a question from Hannah. If patient is in thrombolysis window, should we give aspirin or await stroke review first and reason re-thrombolysis? Very good question, Hannah. We should refrain from giving aspirin whilst the patient is in thrombolysis window, because if they're going to get an IVLT place, that's a preferential treatment. Having aspirin on board increases their hemorrhage risk. So if you couldn't get a CT angiogram for your patient who had an anti-circulation stroke, then do arrange a carotid Doppler. But the meaningful benefit of having carotid Doppler is only for those group of patients who haven't ended up having a severe stroke. So if the stroke is severe enough to make them bedbound, or they're very limited in the mobility, or they are cognitively significantly deranged, then that group of patients would not be benefited by carotid endarterectomy, because the purpose of doing the carotid endarterectomy is to prevent future major disabling stroke. And if the patient is already majorly disabled with a modified Rankin score of 4 or 5, then it's a difficult case to argue with the surgeons. So generally, your radiology department would be hesitant to do a Doppler in somebody who's not deemed suitable for carotid endarterectomy. So just to bear that in mind. So as part of the stroke workup, we routinely screen patients who had ischemic stroke for proximal atrial fibrillation. The national guidelines are still elusive how long you need to monitor your patients for a proximal AF. You could start with 24 ambulatory ECG, and you can increase the window of monitoring based on patients' clinical profiles. So for younger patients, I tend to do a longer period of cardiac monitoring if I have strong suspicion that it is a cardioembolic stroke and my initial 24 ambulatory ECG has shown a sinus rhythm. So based on the merits of what etiology you're suspecting, you are okay to give a longer period of ambulatory cardiac monitoring to your patients. So let's discuss another case. This one is a 66-year-old man who collapsed at home with right-sided weakness and headache at around 4 o'clock. He's brought to you in the ED at around 5 o'clock. Again, he's alert but dysarthric with right hemiparesis. He has vomited twice in the emergency department. You've scored his NHS as 8. His blood pressure is 194 by 104. His pulse is 76 per minute. He's already taking dabigatran 150 milligram BD for his AF. What would you do? Obviously, no brainer. You'll arrange a scan. And scan shows posterior fossa bleed. So the question is, what do you do if it is a bleed? Obviously, the first thing is it's a posterior fossa bleed. It's at high risk of causing raised ICT in the posterior fossa and death through the coning. So you'll be seeking the neurosurgical opinion and advice on intervention. For this bleed, they might want to hold on and ask you to repeat the CT scan if there's a further fall in his GCS, with a view to do a posterior fossa craniotomy, where you may well stabilize with this bleed, and you may be better off by focusing on his blood pressure control. So current target for blood pressure control in an acute intraparenchymal bleed is to keep the systolic blood pressure to 140 mark. You can use IV levotiol or GTN infusion for it. They need close neuro observations because their neurological condition can quickly deteriorate, needing repeat scan and the appropriate interventions based on the repeat scan. And the posterior fossa bleed patients, usually they don't come get the complication of seizures, but the anterior fossa bleed, especially the cortical lobar bleed, are at risk of seizures. Again, the basal ganglia bleeds, they don't tend to have seizures, and often the seizures will be driven through coexisting pathologies, like somebody who's got a dyslectolytemia. So that's a differential for their worsening GCS. They can have further bleed, leading to rise in intracranial pressure. They can develop hydrocephalus, seizures, and sepsis through the low GCS. So, and sometimes you will come across patients who came with the neurology, but they have improved, i.e. they had a transient ischemic attack. By definition, they should have had complete resolution of their symptoms, and that means their NIHS score should be 0. And for the GP setting, the advice is that they can start them on 300 of aspirin and then refer them to the TIA clinic, where we do appropriate assessments and consider brain imaging, preferably MRI head, if there's a diagnostic uncertainty. For anterior circulation TIAs, I've told you before, you need to arrange a carotid Doppler and give them the appropriate secondary prevention treatment, which is antiplatelet therapy and statin therapy. You will do the routine bloods, which will essentially always include a lipid profile, HbA1c, ESR, and mostly TSH as well. And cardiac monitoring for outruling paroxysmal AF is again a mandatory part of their neurovascular. So erythrocyte sedimentation rate. So ESR is high in patients who have conditions like giant cell arteritis or myeloma. Both these conditions predispose the patients to thrombotic stroke risk. Echocardiogram, mostly for all, but very old patients don't tend to get the benefit of getting the echocardiogram because uniformly they get onto an antiplatelet and a statin therapy. For younger patients, you definitely want to investigate more to pin down the underlying etiology behind the stroke. Often the young patients would not have atherosclerotic disease burden. And if they don't have coexisting diabetes and smoking as a risk factor, then you would want to investigate them for acquired thrombophilic disorder or vasculitic disorders. I haven't touched upon patients who are prothrombotic due to an underlying neoplastic condition, but that is a growing number of cohort which comes as an ischemic stroke. So if we see a multi-territory ischemic stroke in whom we are not suspecting a cardioembolic cause, then we do screen them for underlying neoplastic disorders. So that brings to the close of my talk. I'm open to the questions and a round of discussion.
Any questions on stroke with Dr. Yadav, who's an expert in stroke medicine? We have just about 5 minutes before we break. So please put them in the chat box.
So Dominic, 24/7 availability of thrombectomy is improving. Answer is indeed yes. I think the nationwide, the emphasis is on reducing your hyperacute stroke center and diverting the ambulances to your neurosciences center, who tend to have neuroradiology, neurosurgery backup under one roof. For example, in West Midland, 8 years before, we had 9 hyperacute stroke centers, and now we have reduced ourselves to 5 hyperacute stroke centers with 3 neurosciences center Although unfortunately, barring two, the one is struggling with the interventional radiologist presence. So allowing the resources, most acute strokes would be better off being treated under a neurosciences center. Any other questions? So touch on stroke mimics. So remember, loss of consciousness, severe headache, bilateral vision loss, generally not because of ischemic stroke, and that. So you need to search for other coexisting pathologies. Stroke doesn't come with positive symptoms. Usually the stroke symptom complex is about loss of function. So involuntary movements or visual blurring where you have flashes of light or zigzag lines, or a bad headache, or usually not a marker of an acute ischemic stroke.